Bismillahirrahmanirrahim. This is Dr. Shahana. We are discussing pharmacy practice. Today's lecture is linked to the angina pectoris. We have discussed the beta blockers and the nitrates, and now other types of treatment options. What are the other types of treatment options for the angina pectoris? We have calcium channel blockers. Calcium is very important for the muscular contraction. It basically depends on the calcium influx. In case of ischemia, there is more calcium influx as the membrane is depolarizing more due to the hypoxia. This promotes the overactivity of the ATP consuming enzymes and depleting the energy stores and worsening the ischemia. The use of calcium channel blocker initially protect the tissue by binding the entrance of the calcium into the cardiac and smooth muscles of the coronary and the systemic arterial beds. Therefore, all calcium channel blockers that are the arteriovasodilator that decreases smooth muscle tone and the vascular resistance. They are very helpful for the angina pectoris, especially if beta blockers are not used. Mainly they are reserved for the unstable angina, that is effort-induced angina, that reduces the myocardial oxygen consumption by decreasing the vascular resistance. They reduce the myocardial oxygen consumption and they reduce the afterload. They are also helpful for the myocardial infarction in case of hypertension or in case of arrhythmias. So in these situations where beta blockers are avoided, we can also use the calcium channel blocker. Verapamil is cardioselective, while amlodipine has effect that is due to the relaxation of the or decreasing of the vascular resistance of the periphery. In short, we can say that verapamil mainly affects the myocardium, while amlodipine mainly affects the peripheral smooth muscles in a peripheral vasculature, while diltiazem have an intermediate effects. They also reduces the blood pressure. Verapamil is a non-dihydropyridine calcium channel blocker, and it decreases the AV conduction, decreases the heart rate, decreases the contractility, and decreases the blood pressure. It has a weak vasodilatory effects. Mainly it has the effect on the heart and it slows the conduction of the heart. Problem is that they may worsen the heart failure due to its negative inotropic effects. So it is not mostly used. Mostly amlodipine is preferred due to its arteriolar vasodilatory effects, and it has a minimum effects on the cardiac muscles. Nifedipine is another example. It is basically available in extended release formulation. You should remember that short-acting dihydropyrimidines should avoid it in the coronary artery disease because of the increased mortality rate after myocardial infarction. यानी अगर myocardial infarction हो जाएगा तो फिर हम short-acting use नहीं करेंगे, especially in hypertensive patient. Almost all types of vasodilators have the flushing and headache effects due to the dilations of the vessels, especially related to the CNS. Calcium channel blockers, CCB, have a role in controlling of the myocardial function, as well as they have the vasodilatory properties, especially in case of the diltiazem, that have a dual effect. While verapamil also improve the system, however, it is avoided in the compromised left ventricular function, and if there are conductional abnormalities. Mostly, they are reserved for the alternative to the beta blockers in those conditions where beta blocker is contraindicated on that condition, just like in case of the respiratory disease, just like in case of the peripheral vascular disease, then these should be considered. Furthermore, their combination with beta blocker is not a good combination, as it has a more pronounced bradycardia and cardiac depressive effect that should be avoided. The thing that you should remember is that the calcium channel blocker are the drug of choice for the Prince metal angina. Another drug that is ranolazine that inhibits the late phase of the sodium current improve the oxygen supply. It reduces the intracellular sodium and calcium overload and improving the diastolic function. It is considered as an anti-anginal as well as the anti-arrhythmic. The main fact is that it is basically reserved for the chronic angina, and either it is used alone or in combination with the other traditional therapies. Mainly it is reserved for the resistant type of the angina where other anti-anginal therapies are failed. It is extensively metabolized by the lipid cytochrome P3A system, and there is a chance of the numerous drug interaction. Furthermore, it has no hemodynamic effect. Side effects include the dizziness, constipation, nausea, vomiting. The most problematic side effect is the potential for the prolongation of the QTC interval. This is the main adverse effect which leads to the cessation of the therapy. Another important drug is the Nicorandril. Nicorandril is a vasodilatory drug that is meant for the management of the angina pectoris. The most important feature is that it has a dual properties, and it is a nitrate as well as it is a potassium channel opener. This nitrate, as same with that case of the nitroglycerin, dilates the large coronary arteries at very low plasma concentration. However, if concentration is high, it also reduces the coronary artery resistance, which is basically related to the opening of the ATP sensitive potassium channels. Nicorandril has a protective effect, and it appears to be due to the activation of the ATP sensitive potassium channels. Adverse effects are flushing, palpitation, headache, mouth ulcers, nausea and vomiting, GI irritant basically. Another drug is ivermectin. So ivermectin is a mixed type of an agent having a sodium potassium mixed converter current that basically act on the SA node and reduces the heart rate without affecting the force of contraction. And it has a similar efficacy that just like the beta blockers and the calcium channel blockers, and it is reserved for those conditions in which beta blockers are contraindicated. The main important problem is the problem regarding the visual problems that are due to the changing in the concentration or due to the changing in the cyclic nucleotide concentration that are present in the retina. Visual symptoms are reversed after the continuous treatment as the therapy is ongoing. The patient is initially unable to perceive the high intensity light, and there may be enhanced feeling of the enhanced brightness. ACE inhibitors are the drugs that are mainly established for the hypertension and the heart failure. They have proven the beneficial myocardial effect, preventive myocardial effect. They have the vasodilatory effect due to the inhibition of the production of the angiotensin II. They have anti-inflammatory activity, they have anti-thrombotic activity, and they have anti-proliferative activities. Due to these activities, one can be expected that they may have beneficial effects in the coronary artery disease, in which there is an inflammation, there is a proliferation, there is a thrombosis. So several trials were conducted, and ramipril is found to be very safe in different types of trial, especially in the diabetes patient in long-term therapy. Now the use of the ramipril decreases the chances of the stroke, myocardial infarction and other cardiovascular death, and there also a benefit that is independent of the reduction of the blood pressure. Now the ACE inhibitor is become a part of the regimen of the anginic patient to reduce the chances of the further complications related to the blood pressure and diabetes. Another class of drug that mainly responsible for the reduction of the occurrence of the angina, these are the statins, and several studies are there which mainly focusing on the patient that have the elevated cholesterol. We have to reduce the level of the LDL to a certain level to reduce the chances of the angina pectoris. In addition to the cholesterol lowering properties, these statins also have an anti-thrombotic, anti-inflammatory and anti-proliferative property. Furthermore, they are restoring the normal endothelial function and inhibit the production of the ROS, which are the reactive oxygen species. They are the part of the primary drugs that are usually prescribed to a person to lower the cholesterol, especially in the obese person. So those patients with are having the problem of the stable angina will be on the statins, and they are mainly for the cholesterol lowering effects. However, other cholesterol lowering effects, as we have discussed, are also appear that make the person somewhat to the even level to the normal cholesterol level. They are even prescribed in those persons in which the cholesterol level is normal, to reduce the chances of occurrence of the angina due to any other reason. कहाँ देते हैं? जहाँ कोलेस्ट्रॉल नॉर्मल भी होगा तब भी दे देते हैं. क्यों दे देते हैं? ताकि जो अदर इसके इफेक्ट्स हैं, एंटी थ्रोम्बोटिक और एंटी पॉलिफरेटिव और रिएक्टिव ऑक्सीजन स्पीसीज को जो रिड्यूस करते हैं, उसको करने के लिए कभी कभी डॉक्टर इरेशनली स्टैटिन भी प्रिस्क्राइब करते हैं. एज वी हैव डिस्कस्ड दैट यूजुअली नाइट्रेट्स इज रिजर्व टू रिजॉल्व द सिम्पटम ऑफ द चेस्ट पेन, and for that person GTN, that is the glycerol trinitrate, is now the drug of choice. However, sometimes it may happen that the pain is not controlled by the use of the nitrate. In that condition, intravenous morphine should be administered, especially if there is chances of the STME, that is the ST elongated myocardial infarction. These morphine injections are administered together with an antiemetic drugs, that is prochlorperamazine or metoclopramide, to reduce the side effects of the morphine inducing emesis. There is no benefit that we leave a patient in a pain before the diagnosis is considered. Pain is basically a sympathetic activation that causes the vasoconstriction and increases the workload on the heart, and also exacerbate the underlying condition. So it is necessary, if there is no proper diagnosis, unless and until there is a proper diagnosis, the pain should be managed immediately. As antiplatelet therapy like aspirin tablet should be chewed as soon as possible, and the daily dose for at least 1 month should be used to reduce the mortality and the morbidity. So aspirin is probably you have to take throughout the life, and it will also reduce the mortality. Another drug is the clopidogrel, that give the addition to the aspirin, that further improve the coronary artery blood flow in addition to the absolute reduction in the mortality. However, these all therapies are reserved for the restoring of the condition in the patient with the STMI. We will separately discuss the STMI in another lecture. For the management of the acute coronary syndrome, we have other types of the management as well, like fibrinolytics, like streptokinase, altiplase, ratiplase, tanicotiplase. These are reserved for the condition in which the aim is to restore the coronary arteries due to the blockade of the coronary artery, and this is basically the treatment strategy that should be recommended by an expert that deal with the angina pectoris or the cardiologist. In case of acute attacks, fibrinolytics are actually administered in a hospital setting. There is a number of conditions in which they have to be considered, either they are considered along with the aspirin or they are considered alone. This is all about the miscellaneous drugs related to the angina pectoris. Thank you.